This is the position, the classic position for the posterior dislocation. So it's very painful. When you see this classic position at the emergency room, don't forget to thinking about the posterior dislocation. And many times the patient may have some injury to the knee joint, like patellar fractures because dashboard, right? Like what else? Dashboard. Which ligament? Which ligament? Posterior cruciate, right? Can be torn. So very common PCL or posterior cruciate together with the hip dislocation. Many times you miss the cruciate because you can see this obviously from X-ray, but from X-ray you cannot see PCL injury. Right? Okay, and many times the patient have broken tibia or femur. So these are the mechanism of PCL. So if you are the first doctor, what do you do? April, come here. Yes.
Then set like we're sure that there's a intervention, you have to try force reduction in the lower emergency
you should do something else before send patient to operating theater. What should you do first? Immobilize. By casting? Slap. Spring. Doesn't help. It's useful for extremity fracture, like you have fracture around the knee, ankle, forearm, distal radius. No, pelvic biter is more painful, produce more injury. You do some examination.
Neurovascular.
Yeah, when you have fracture or dislocation, thinking about the distal, right? Distal neurovascular. It's a common injury. And how to test it? Sciatic nerve, right? Because the posterior dislocation, the head will bending on compressed the sciatic nerve. But the anterior dislocation, this is the position anterior dislocation. Abduct is located in big bite injury, hitting on the middle side. But dashboard is okay. So this posterior. So what do? You're the first doctor. You can do like stand leg lessing test, right? No. Are you sure? Sure. So in the examination, you always say like stand leg lessing test. It's weird. So you should not answer this question.
Like can you move his toe?
Okay.
Or like is there numbness?
Numbness and
The house of the
what else?
So the
Can they like extend the knee get painful, right?
Cannot move. It's painful. Just
this.
so the sciatic nerve composed of two components, right? There are tibial component and peroneal component, right? Which component may injure? Often injure. Peroneal component. So what would happen? Foot drop. Okay. So you just check that the patient foot drop, right? Dorsiflexion. If the patient cannot do dorsiflexion, and mean the patient has sciatic nerve injury, the peroneal component. Tibial component is rarely injured. Right? So very simple, check the foot drop. Okay? The vascular injury is not common. It's common in knee dislocation. So the nerve is more common than the vascular. What else? Immobilize. Because the patient in this position is not easy to immobilize or to touch the patient. You should transport in these patients to the emergency, to the X-ray, because it's very painful. You should not move at all. You should not try to traction, no, because you can do more harm, right? If you do that, the patient may resist you and can create fracture of the neck of femur. So that is the worst complication, right? The patient may have vascular necrosis. You change the prognosis of the patient. Okay? So I saw 2 patients like this in my life. There's fracture after they try to reduce or manipulate the hip at the emergency room. Okay? So check the nerve and don't forget to check this. The knee. Why? Yeah, because the fault is coming from the knee joint. So the knee always injured. Fracture patella, PCL, knee dislocation, can be small fractures, finger fractures. And also sometimes patients also have hip fractures because there's axial loading. So check the knee, is there any hematrosis or allotment? Right? If you see the knee is not normal, there's some bleeding in the joint, that means there's something happened in the joint. Okay, after that, send the patient for X-ray. Okay, X-ray. So how you order hip X-ray? Packing white, huh? Again? Film hip AP?
Both hip.
Huh? Both? No.
Pelvis.
No. Both? No.
Pelvis.
No. What hips? Are you EP student?
Okay.
What you miss is? Again? What hips? AP. Okay, what hips AP? Okay, you see there any? You need another side to compare, right? Especially after the reduction, and then it's obviously you have simple dislocation or complex dislocation. The meaning of complex is always associated with bone fracture, like elbow, right? Elbow dislocation with coronoid tip or radial head, we call this complex. Also the knee dislocation, you have fractures around the knee, also we call the complex knee fracture dislocation. So the hip, after X-ray, you can see this dislocated. So what's next?
Do we need to film like the knees or the knee?
Yeah, if you suspect, then you can do the name as well, but not easy because the patient in this awkward position is not easy. You can do it later, okay? Or you can do like lateral cross.
Lateral.
Okay. It's not easy to stretch the knee joint. Okay. So what will you do next?
You will have to like to send the for post reduction.
Reductions.
Under general anesthesia.
Okay.
Then like repeat the film both is
Okay. Good. How to do that?
traction.
Traction. How to traction?
Alice.
Alice maneuver.
So we like traction the leg out first.
Do yourself.
No. Orthopedic.
We need some.
Consult on the traction.
No. I mean, you do it yourself, or you do it alone, or you need some assistant. Okay, call one assistant.
Assistance.
Okay. You are the assistant, or you are the doctor? Assistant. Where you stay? Assistant stay over there. Doctor stay here. Okay. So tell your assistant to help you.
Help.
The assistant will. Okay. Hold the pelvis. Okay. Assistant hold the pelvis. And you?
Traction.
No. Not traction.
You have to take out the
No.
no.
No. You can break the hip.
External rotation. Can we external rotation?
ทำเข้า
No.
External rotation.
เสร็จแล้ว
External rotation.
No.
Flex more.
Huh?
การ
Flex more. ยกขึ้น upward.
No. Okay. So after stabilize the hip, right? Okay. And then you bend because the patient in this position. First you bend the hip this way, okay? And then you perform this traction. Okay? This traction. The assistant stabilize the pelvis. Okay? And do this way, okay? Most of the time you let the patient on the floor. Right? The stretch on the floor. And the anesthesiologist also stay on the floor. Okay? Understand? Because it's easier for you to do this. Okay? And then you hold the leg like this and perform axial loading. Axial pulling. Pulling this way. Okay? It's not easy because the muscles around the hip is a lot. Okay? You need to track the hip from the socket. Because it dislocate like this, right? You need to slowly do it, and then the hip muscle will pull the hip joint, the hip back. This is Alice technique. A-L-L-I-S, Alice maneuver. Okay, this way. Okay. Another way is you can do this. Okay, this is like you can put your knee, right? The good thing is that you don't need to bend too much. It's not good for your back. Right? You can put your knee like this, okay, and then you use your knee as a fountain, okay, and then you put this down, okay, and your knee is pulling this way, okay. This way, okay. So the hip will be reduced, okay, and you can feel its muscle reduced. Understand? This is the name is from I think Russian something. The name is Lev Kovitz, not Covid.
Kovitz.
Lev Kovitz. L-E-F K-O-W-I-T-Z. Lev Kovitz. So there's one student writing C-O-V-I-D. F-E-F-T. Lepkovitz. See that? This is Lepkovitz. Yeah, you put this down, and the knee act like a falcon, right? You see this picture? Okay, this is a Lepkovitz technique. Okay, for the hip reductions. Okay. So another way is to turn the patient, but this position is not so friendly. Okay? You drop the knee down this way. Okay, like this. And put the patient on the edge of the table, right? Okay, bend the knee like this way. Okay.
Right now.
So this is the position of dislocation, right? Okay, but it's not easy because you cannot control the patient airway. Okay, so they put this way and then they push it down. Okay, someone stabilize the pelvis, right? Put this down. But it's not so popular. The Alice is most popular. Okay. Alice technique.
You remember?
And and after the reductions, you check the films again, right? To see that this was reduced or not. Away both sides. Because after the reduction, sometimes the hip It's not completely reduced. You can see from X-ray. The joint space of both sides not the same. Or sometimes there's some broken bone. Broken bone was entrapped into the joint. So that's very serious. If you have some broken bone entrapped into the joint, because it's that act like the third body wear, loose body in the joint. Your cartilage will damage. So in that situation, you need to do the surgery for the patient to remove the fragment. Right? And to remove the fragment from the socket is easy or not? Why?
You have to dislocate.
You need to dislocate it, right, and take it out. And what is the easiest way to do that?
In the OR.
What's the easiest way?
Internal.
When I was very young, when I was graduate many years ago, so I have one patient that have encapsulated, we call encapsulated fragment after hip reduction. So I take like 2 hours to take the fragment out, and finally this patient had vascular necrosis. Yeah, 2 years after that. A very bad memory. But nowadays you can take that piece of bone out very easy. How to do that? Arthroscopic. Okay. Arthroscopic. You don't need to dislocate, right? You distract the joint, you put the camera inside, and you take it out. 15 minutes. Easy and safe because you have no vascular injury. But if you want to take this fragment out, it's here in the joint. It's not easy. You need to dislocate, right? And you take it out and reduce it back. Okay. So keep in mind, check X-ray both sides and check the nerve again after the reduction. เป็นลีดเหรอคะทางนี้ฮะ
Copy position.
Okay. Any question? So these are common dislocation of lower extremity, right? The upper is the shoulder. Shoulder number 1, elbow number 2. For the lower extremity, number 1 is hip, number 2 is knee, right? For knee joint, you know, it's very serious, right? You need to check the vascular. I think you see one patient, right, at the one brow, right?
Yes.
One patient? No.
Vascular.
Vascular, yeah. The first week.
shoulder ที่เขา
Bedside teaching. Yes. Like first week you, right? I think first week she's a lady with the motorbike accident. Dislocation. Right, remember that?
Yes.
Yeah, that is the dislocation.
From the X-ray, it's like incarcerated. Like after, it's like moving
Oh, you mean this one, right?
incarcerated.
Yeah.
Like
So this is a good example. You show your friends. Can you show in the monitor? Everyone can see. So from this picture, actually you cannot see anything, right? But I tell you, you need the both hips X-ray, right? And the key point is that the middle of the spine, the sacrum, should be in the center of the pubic symphysis, okay? Because this should be symmetrical. And we look at this. This is we call teardrop, okay? To the head. You look at this side, and you look at this side. Is that the same? Which one is wider? This is left side. This is wider, right? Sometimes you cannot see any fragment. You see any fragment? No. You see any fragment? No. Okay? But you see the joints wider. Okay? This is a good example of the incapacitated fragment. Because sometimes the fragment of body is like cartilage. Yeah? It's a piece of cartilage and you cannot see the cartilage from the X-ray. Also control. Yeah? So always looking for this joint space. This is a good example. Okay, send this picture to me. Very good, you can find this picture. It's a good example. Sometimes you can see, but the best way to see this fragment is with which investigation? Investigation of choice. CT scan. For CT scan, you can do like removal. You can remove the acetabulum, right? You can subtraction, and you can see very well the fragment. MRI you cannot do subtraction. Okay, so these are good examples of carcinoid fragment.